Thank you all very much for coming along tonight. I hope you've got your fill of food. Don't worry, there'll be more food through the evening. There's a couple of parts of the evening where we'll be watching some videos, and I can promise you that our catering staff tonight, care of the Doctor's Choice Low Carb Cafe, will be coming around with a lot of food to keep you nice and happy. As you can see here, we've got a very tight packed schedule, and I'm really looking forward to the workshops there. And what we'll do in those workshops, after the didactic talks, we'll break up into a couple of groups. We've got a virtual surgery down the back of the room, and then at the front of the room we shall conduct a little functional movement program with you guys, and we'll assess how you guys are moving. So I would just like to take the opportunity to introduce our movement therapists who are going to just come up the front here, because these guys are really the future of spine care. Okay, I'm convinced of it. I've been working in the spine health industry for over 15 years. These guys are the future of spine care, and they're all extremely passionate about what we do here. And I can even name them all: Joe, Lockie, Kate, Maddie, Luke, Alice, Sam and George. So this is our fantastic team, and they take great care of our patients and are extremely passionate about our philosophy and approach to treating back pain. And if we're trying to establish a clinical centre of excellence, which is really what our vision is, to have Brisbane GPs know that St Andrews is the default location to send your patients with back pain, we have to have a premium team behind that claim, and these are the guys that do all the work. Okay, so they're like the driving instructors for the human vehicle, and that's what functional movement is really about. It's about teaching people how to move their bodies correctly again. All right, thanks, sir. So let's start with the big question. I've already had a great chance to talk to some of the audience tonight, and it's really enlightening already to hear some of the stories that I've been told about their practices and back pain and their views on back pain. Back pain is one of the most significant causes of disability on the planet, and really there's a few principles that we need to focus on if we're going to get control of this epidemic. And number one is recognizing that we're not doing a great job at the moment with managing the condition. Okay, so this is a little pie graph, and it represents the 1.5 million people in Australia today with chronic low back pain, and I think our population is around 24 million or something like that. 1.5 million people today have chronic low back pain, meaning that their back pain has been present for over 3 months as the general guideline for what is chronic versus what is subacute or acute. And this sliver of orange here really represents 745 people from our health registry that have had surgery for their back pain, for their chronic low back pain. 745 out of 1.5 million. So essentially 1.5 million people are really out there in the community looking for a solution for their back pain symptoms. Okay, and if we think about what the statistics show, the World Health Organization just this year came out with a statement saying that low back pain is the single leading cause of disability on the planet, and that absolutely shocked me. And I work in the back pain therapeutic industry when I saw this, and it really resonated with me that what we're doing out there just needs to change. And I don't know if you've seen any other functional movement therapy centres in your travels around Brisbane, but I certainly haven't. And we really represent the only functional, specific and distinctive functional movement therapy centre in Brisbane. Okay, we do have a centre on the Sunshine Coast, and further north up in Mackay. So a large proportion of the back pain therapy industry is really massaging the natural healing process of the body and claiming that as treatment. A lot of conventional therapy, therefore, is coincidental, not causation or cause for symptom improvement. And hence it's no surprise at all that relapse rates for acute low back pain approach 75%. Okay, so if you have an episode of back pain one weekend and you do whatever therapy is advised of you, or whatever therapy you choose to do independently, whether it's going for a massage or going to the local chiropractor or physiotherapist, the likelihood of you having another episode that year is about 75%. So that tells us that the actual cause of that person's back pain has really not been adequately addressed, even though the symptoms got better. Okay. So causation can be broken down into three main three main principles: structural deficits, functional deficits, and an unfavourable capacity demand balance. Okay. Structural deficits are pretty obvious. If you've got a ruptured disc or a fracture or a tumour or an infection in your spine, that's going to be painful. Okay. No sort of brain power required to appreciate that. Functional deficits are a little bit harder to understand, and by the end of this evening I hope you will all have a fantastic concept of what we mean by a functional deficit as it relates to your spine or spine health. And then this last one, this balance between capacity and demand, is probably even less considered when there's a patient sitting in front of you in your office with back pain. I bet you're not thinking what is their capacity and what is their demand. Okay, but that is actually the ultimate metric of what we need to be targeting if we're going to eliminate the disease that causes the back pain symptoms. Okay, so the key to understanding this important concept is to recognise that structure, function and capacity are all interrelated, and our ultimate goal is to have a functional capacity higher than our functional demand. Okay? And that just means that we can do more things. If we have a high functional capacity, we can just do more things. And if we can do more things than what is required in our own individual life, then we're going to have a robust, healthy, pain-free musculoskeletal system, which of course includes your spine. Okay? So let's focus on the structure and function of systems. Every system's efficiency or capacity, whether it is biological or mechanical, is dependent on this important principle and interrelationship. Will a software reboot fix this iPhone? No, of course not. It needs a structural repair. It needs the glass fixed, okay? And yet, in the case of severe depression, if I put that person into an MRI scan to scan their brain structure, am I likely to see an abnormality? Absolutely not, because it's a functional problem. And there are many examples of this in biology and physiology. So I've got a mechanical example there. So structurally flat tyres will make a car dysfunctional, okay, difficult to control. And likewise, a person who's driving the car poorly with dysfunction will create structural changes in the car. And in biology, if you have a mitral valve stenosis, for instance, which is structural, then you'll have a high chance of developing a functional arrhythmia. And then if you have a functional arrhythmia, that will interplay and interrelate and create potentially a structural infarction. So structure and function are very, very much interrelated. And nowhere is this principle more relevant than in spine health. So I don't have a perfect spine like this image here, okay? That's not me. And I don't move, I don't function like this Olympic weightlifter breaking a world record, okay? But as long as the interrelationship of my own structure and my own function meets my personal functional demands, I'm going to be pain-free and healthy. Okay? So I see lots of people with perfectly normal MRIs like this who are still disabled with low back pain because of terrible function. And less commonly, we will see very good athletes who function well, who may have some structural deficit, some structural weakness in their spine, for example, a pars defect, for example, a little spondylolisthesis, and regardless of them moving very well, that structural deficit will compromise that interrelationship and therefore open them up to the risk of pain and disability if they try to exceed their functional capacity as they approach that capacity demand balance. The most common situation, however, is that the patients acquire progressively poorer function, which drives progressively poorer structure, and they walk a tightrope of trying to keep their capacity and demand in check, or risk the onset of pain if the balance tips unfavourably for them. And this is why we hear patients telling us that I used to do the washing, but that hurts too much, so I don't do the washing anymore. I used to go for walks, but I don't do that anymore. I used to enjoy sport. I don't do that anymore. That is then unconsciously changing that seesaw, that balance, to make capacity, which is very, very poor, match their demand. So they're just dropping their demand so that the capacity meets it. Okay, and that's called maladaptation. Okay, maladaptation is akin to being in quicksand. It only just gets worse. The more you maladapt, the worse you become. You might get through today by not going for that walk or by not doing that washing, but in next week you're going to have to maladapt even more to continue to keep that balance in check. So we all have to meet functional demands in life, be it a mountain climber, an office worker, or a nursing home grandma. How can we actually optimise the functional capacity in this equation here? Well, it's really quite simple. We optimise the structure with structural remedies, and that may involve surgery, and we optimise the function with functional movement therapy, which is the functional remedy. Thankfully for patients, only a tiny proportion of people need a structural repair. Only a tiny proportion of people need a surgical structural repair for their back pain. But almost 100% of people with back pain need a functional repair. Okay. So what is functional movement therapy, and why do we call it NeuroHAB? Because it is distinctive in its target being the central nervous system motor patterns that dictate your movement proficiency. Central nervous system motor patterns. So therefore we have rehabilitation of the central nervous system, and that's why we coined that word. Think about it being like brain training to move skillfully in daily life activities, or what I refer to as the sport of life. Because like it or not, you are participating, you are playing in that sport of life. And I think we should all strive to be good at it. We don't have to be good at the sport of life, but if you're not good at it, you're going to have a low functional capacity and you're going to risk that balance tipping unfavourably for you. Thus, functional movement therapy and NeuroHAB is very different to conventional rehab approaches, which can be viewed more as low potency fire extinguishers attempting to suppress pain symptoms, in contrast to movement therapy, which is like putting the arsonist in jail. Preventing the root cause of the fire symptoms and future recurrences. So when you think about it, these are really structural methodologies with zero upskilling of movement proficiency or skillful function. Another way to conceptualize the NeuroHAB program, as I alluded to at the beginning of the talk, is we're like the driving instructor for the human vehicle, and that spares you from having to go to the mechanic all the time. I'm a mechanic. Most people practicing in the back pain therapeutic industries are mechanics. There's not enough driving instructors, and so because there's not enough driving instructors, everyone's out there moving terribly and repeatedly having to go to get their structure fixed. Think about facet joints, epidurals, the medications that people use to control pain symptoms. That's equivalent to going to the mechanic all the time because you're not a good driver. And we're going to the mechanic. We're going to Pilates or gym-based core strengthening exercise programs make you stronger. And I was talking to a doctor earlier this evening about exercise programs, and we are not an exercise program. We are not a strength and conditioning program, because when a patient goes to a exercise physiologist or a physiotherapist, he knocks on their door because he has back pain. That's what he goes there for. What he leaves with is a core strengthening program. And yes, he's going to become stronger, but strength does not mandate proficient movement. And therefore, even though he's now got his six-pack and he might be fitter, he's not necessarily moving better, and therefore after 6 weeks, 8 weeks, 12 years, he still has back pain. Okay? And when you have back pain for 12 years, like a lot of our patients, there's a lot of other things that start to complicate the issue. But really, the complexity of it is simply because right at the beginning of that episode of care, the therapist did not conceptualize movement proficiency. So is low back pain complex like much of the industry? And every single article that I read in the peer-reviewed literature is talking about complex management algorithms, okay? Multi-dimensional, cognitive behavioral, biopsychosocial, managing depression. These are really way downstream problems. And I'll explain that because, like, in this way, I'll see a patient who's sedentary, overweight, they'll be deconditioned, very inactive, they'll express being tight all the time, they'll talk about the family history of everyone having back pain, they'll be elderly, okay? And these are what people attribute for years and years and years as the cause for their back pain. And what I have to say to that patient is, hang on, the patient that I just saw before you was very active. Okay, he was a physical worker. The patient I just saw you was lean and underweight. The last patient was a triathlete. Flexible people have back pain. And young people who've had surgery continue to have back pain. So this is not a suitable explanation for that back pain, and we can't sort of lazily attribute pain symptoms to these wrong and incorrect, misinformed discriminators because it just suits that scenario. And what it also does, it delays acquiring the actual effective therapy. Okay. So the discriminator or disease causing low back pain is this, and really this is not in the textbooks. Okay, it's not in the textbooks. Movement dysfunction can be considered to be a disease. Okay, so when you see a patient who has back pain, you can now hang a hat on that you can now give them a diagnosis Whereas in the past, you just said, oh, you got low back pain, you got degeneration, you got inflamed joints. But now you can say you got movement dysfunction, and that is what's driving the irritability of whatever downstream structure it may be. Okay. So this is you guys tomorrow, and I'm sure you're going to see someone with back pain tomorrow. I keep having flare-ups of back pain, doc. I've done everything and it's getting worse. You go, I wonder what her spine structure is like. More importantly, what is her spine function? I bet she moves poorly, setting her up for poor functional capacity. She has a disease of movement dysfunction. I better send her to the Back Pain and Functional Movement Training Centre for the NeuroHAB program. Okay, it's a shameless plug, but that's how we need to be thinking if we're going to get on top of this epidemic that is the world's leading cause of disability. And no one is thinking that way. No one is thinking that way. I'll show you a little video here. There's absolutely nothing wrong with this guy's spine. So he had a work injury. It was a very minor work injury, nothing horrendous, just sort of getting up off from underneath a truck that he was servicing. And then he went straight into physiotherapy, reflex action, straight into physiotherapy, reflex action, straight onto the couch. And I asked him, what do you do for the half an hour that you're there? And it's all manual therapy or prolotherapy or deep tissue release, of course analgesia, off work. And you know, he was convinced that there was some rusting nail in his back. And of course he has an MRI and it's completely normal. And so if it's not a structural problem that's driving this pain and disability, it can only be a functional problem, all right? But you know, it's just so far out of people's thought processes that they never ever get to that. So if they're thinking about epidemics, right, this perfect storm here. Note that epidemics by definition usually have a very simple root cause, otherwise they can't ever become an epidemic. The condition of low back pain is certainly considered to be an epidemic now. So it's difficult to imagine how an epidemic of back pain could be created by the currently proposed complex melting pot of biopsychosocial and multidimensional cognitive behavioural factors that would need to come together like a perfect storm in order for you to become a back pain sufferer. All right, that's the end of my little bit about back pain. And that's the most brain-taxing part of the talk. We're going to now talk a little bit about surgical things, because I am a surgeon. I love surgery, but this centre is stopping me from doing surgery because patients don't have pain anymore. So therefore, they've maxed out their interrelationship between structure and function, because their function's gone up so much. That interrelationship is improved, and therefore their capacity demand balance is improved, and therefore they go, well, why would I have surgery? I don't have pain, so I'm not going to operate on someone who doesn't have pain. Okay. So then let's talk about the ones that come too late. The ones that come too late, and this is what we do 2 days a week. We're going to start with sacroiliac joint surgery, because it's really way more common than we believe, way more common than we would otherwise think. You know, prevalence rates for people presenting with back pain in the order of 30%, and